I'm here at the 17th Annual Congress of the International Society for Cardiovascular Pharmacotherapy with a number of colleagues who actually were taking part in a round table on the potential role of HDL in cardiovascular prevention. At the meeting, there were quite a number of important questions, and we will try to discuss at least a few of them, which we felt actually are quite important in this particular, at this point in time and in this particular context. Perhaps, Tony, if you would like to raise the very critical question of HDL as a marker of risk.
I think one of the interesting things that sort of has come out is that we're beginning to question the basis of the underlying lipid profile and how it relates to risk. Now, it's been clear that LDL is a risk factor for ages. Triglycerides have gradually become very, very much more obvious as a risk marker. They don't actually seem to be pathogenic in themselves. One of the questions that came out of this particular meeting was, is HDL a risk factor or is it actually a risk marker? And I think it's a very, very good question because epidemiologically we know that it is a risk factor. That's why it sits in all the studies and in all the guidelines. However, when it comes to modifying it, then the questions begin to actually mount. Because ideally, the difference between a risk factor and a risk marker is can you modify it and actually produce a clinical result? And the thing with HDL is we haven't really got that much data for modifying it. And what data we have for modifying it can be confounded by other factors. So the niacin data, the fibrates don't really do much on HDL.
Would the data, the experimental data plus the epidemiological data would be enough to actually make the assertion that it is really a risk factor as opposed to be just a marker of risk?
I believe that there is more evidence for considering HDL a risk factor than just a marker. As you say, we have a lot of experimental information, epidemiological, but also we don't have pharmacological evidence. Strong pharmacological evidence, we have some, but we have also indirect evidence that HDL can be modified by diet. It's true, you say it's not univocal. I mean, there are other factors that are associated. Drinking moderate amounts of alcohol raises HDL, exercise raises HDL. So all of them are not a direct relation, but it's indirect information that by raising HDL you have cardioprotection.
But you could say that perhaps it's a marker of the good effects that exercise and alcohol have on the vascular system.
That's why we were saying that pharmacologically you're modifying the levels. We don't have strong evidence as yet, but through epidemiology, I mean, epidemiology has taught us about HDL levels and the prevention.
I think the strongest evidence really, as was mentioned in the study, is sort of for the reinfusion, that when we actually take HDL out of patients, okay, it's very, very small scale, it's very translational in nature, but that you can actually take HDL out, delipidate and give it back, and it has significant effects both on lipid profiles and on virtually every single surrogate marker we care to name. And the endpoint studies for one delipidation technology are currently underway in the USA, so that we will actually have evidence in maybe a couple of years with any luck. But that is very strong. Then we had this very, very strange compound, ETC216, which was based on a hyperfunctional HDL, which is ApoA1 which contains ApoA1 Milano, which is a hyperfunctional form of ApoA1, which actually paradoxically gives you clinically a low HDL, but its effects in turnover from basic animal study models are huge. In actual fact, I think one of our main problems with HDL is that we're actually measuring it in the wrong compartment. It's not primarily a plasma molecule, it's actually primarily an intrahepatic molecule, and most of its resin side is actually...
Plus what Jill was raising during her talk was the fact that the heterogeneity of the molecule is such that when you measure, or clinicians measure HDL, what are we measuring?
But the picture that I painted of the enzymes and receptors that modulate HDL, I only elaborated those which are present in the plasma compartment, and I think we're really underestimating the complexity and the mechanisms of modulation of the particle as a population, because, as you say, we're not considering interstitial modulation. and factors that might influence that. So it does get complicated, and clinicians are going to want to know what we measure. Do we measure HDL2, HDL3, ApoA1? And we've still got an awful lot of work to do to go back to our clinical data and interrogate that with regards to how disease and disease modification alters HDL, to know what to do.
One of the questions is, are we measuring the HDL the right way? What we do is effectively a very cheap assay of differential precipitation and measure the cholesterol. Is that the right thing to be actually measuring there? The recent studies we have now begun to get some of the marker models for actually looking at reverse cholesterol transport, and it's potentially feasible to turn those into fluorescent cell sorted assays. That is within the bounds of possibilities with current technology, which would give us an index on reverse cholesterol transport. But should we be looking at that one? You mentioned in your talk inflammation. Should we the HDL and inflammation associated markers? One of the ways that we could actually explain some of the dramatic effects of HDL is its massive anti-inflammatory nature. And we know a lot of the ancillary proteins are related to parasites and viruses, and control of bacteria and bacterial lipoprotein. So are we actually measuring the right function to begin with?
Sure, those effects might explain some of the strange data that we got with ETC216, the lipid-free A1 nanoparticle. Because with all those studies, a very, very small dose of it gave extremely strong results, and it was not dose responsive. So either a very small amount gave a particularly good benefit, or we're missing something entirely. As
I think that
could it be the antithrombotic effects which you mentioned in your talk?
But I think that indeed measuring HDL through HDL cholesterol, as we do, we get the wrong information, because you get very high levels of HDL, but you're measuring cholesterol transported in HDL, not the other functions that we believe are the beneficial functions. But the point is that with very small amounts of ApoA1, you can get extremely high effects. And that was the reason why there was no dose response, because the lower dose was already effective. We have done studies on ApoA1 Milano, trying to understand better how it works. And low doses are really anti-inflammatory. We have huge effects in experimental models. But there is a question that I was thinking now when you were mentioning how we measure HDL and what's the response we get. When we infused the rabbits in the study in the 80s with the HDL, very high density HDL preparations, we didn't change HDL cholesterol levels in the circulation. So, yes. And well, this is written there, but something I have to bring up when I present, because indeed we were measuring HDL cholesterol. HDL cholesterol did not change. When we did the following of the ApoA1, yes, we found ApoA1, because it was the structure of the preparation we infused was rich in ApoA1. And we don't measure that in our method of testing HDL.
The other point is, when we clinicians are trying to increase HDL using CETP inhibitors, for example, are we doing the right thing? Do we have the right drugs? Is CETP inhibition the right way of increasing the high cholesterol, the HDL cholesterol we want to increase? So I think there are lots of questions that still...
One of the problems is that the HDL is far, far more complex than LDL. We have a group of drugs that are established, and we can put niacin into this category, we can put fibrates into it, which are HDL raising in inverted commas. And that's what's been put into the meta-analyses and so on and so on, and the results have come out. When you actually look at what those compounds do, they're actually not directly HDL raising, they're actually particle resorting. They're actually changing particle sizes. The principal action of fibrates, for instance, is to change particle sizes. Similarly with niacin, there is an HDL ApoA1 increased secretion effect. Yes, we know that. But there's a very, very strong triglyceride effect, and there will be a very large particle redistribution effect. That's been shown. So our current mechanism that we say is HDL raising actually isn't. We're actually looking at changing particle shape and size. That remodeling, that's what we have done so far. Now, whether CETP inhibition, which changes particle remodeling but in a very, very different manner, actually comes out with beneficial effects is a very, very open question.
Sorry.
Yeah, no, what I wanted to say is that indeed we should not compare what we get with the drug with the results we can get with the HDL as a risk factor. I mean, with the comments at the session were, well, maybe if CETP inhibitors don't work, it's because HDL don't work. We should avoid that because it could be, this is confusing, well, it's not correct.
Yes.
It's a confusing statement. I mean, CETP inhibitors have to demonstrate if they work or they don't, we will see. But the success of CETP inhibitors doesn't have anything to do with the fact that HDL could be cardioprotective.
I have actually written a small editorial in our journal, in the ISCP journal, Cardiovascular Drugs and Therapy, precisely this concept that I think we really need, particularly academic institutions, should actually get together to try and get the right message across. Because understandably, market forces manufacturers of drugs necessarily would like to see their products doing well and being sold and are used widely. But I think the scientific community really need to try and get together, try and understand which are the real questions, which are the difficulties, and what is the right interpretation of the data we have so far.
I agree.
Yes.
Thank you very much.
It's a pleasure.